first urology resident, the lady clinic, actually, back in the late 50s and early 60s. So, you know, Bob is here, and I've been in Nashville since 1984. And as Ronnie said, is that you know, really what we're going to talk about today is, let's see here, am I on? What do we got to do? We have to change slides. So, okay, here we go. So what we're going to do is we're going to talk about really the role, as Dr. Abaza said, is the role of biomolecular markers in prostate cancer. And I will tell you that urology, we're about 10 to 15 years behind everybody else. You know, as you know, in colon and breast and lung, they've been using molecular markers to basically try to drive therapy for diagnosis. We're prostate, bladder, we're getting there. So again, it's moving very quickly. So actually, when I first put this slideshow together a couple of months ago, when Bob said, hey, you know, you're interested in doing this, I said, sure. I mean, it's changing every week. I mean, there's more data that's actually come out the last week. So I'm going to try to make this, again, sort of more practical and try to not delve too much into the areas under the curve and positive and negative predictive value, but really talk more about the role of biomarkers, and more importantly, in what disease space in the spectrum of where you're going to use biomarkers. So these are my disclosures, and again, basically, like Dr. Abaza said, I've got a big clinical practice. I also do a lot of clinical research. A couple of friends of mine and I started a research consortium where we're heavily vested into the biomolecular world as well as the therapeutic world. So many of you may have seen this. This was in the Wall Street Journal. It was new prostate cancer test, and this was out basically in May of 2016. And again, it's the role as more and more people become aware of prostate cancer. And, you know, as you saw, Ben Stiller just came out recently and said he was diagnosed with prostate cancer, and thankfully he mentioned PSA. So again, everybody in the United States is looking at these new tests. And so when you look at the recent advances in prostate cancer really over the past few years, number one, an area which I'm, again, very involved with, is these multiple new therapeutics with different mechanistic actions in this area of what we call castration-resistant prostate cancer. That's the area where unfortunately the 27,000 people that will pass this year, it's the area that we used to call androgen insensitive hormone resistant. Now this new nomenclature is castration-resistant prostate cancer. But the other area is really this whole concept of prostate cancer markers and basically molecular markers and genomic assays, which is what we're going to discuss tonight. So when you look at the current needs of where we are with prostate cancer, as you know, we've got this task force, United States Preventive Services Task Force D recommendation that says that PSA is not a good test for screening. It's given a D recommendation. And that's a whole different talk in and of itself, but again, as many of us know, PSA is a good test. It's a good test, but it needs to be more judiciously used. Really what we need to do is that we need to increase the likelihood of initial positive biopsy, not that just who's going to have prostate cancer, but who's going to have significant prostate cancer. Because we know not all prostate cancer needs to be treated, and we as urologists, we have been pegged as those greedy bastards that overtreat everybody. We overtreat everybody because we're money-grubbing bastards. That's, I mean, you know, Elaine Mitchell from Georgetown just came out and said that the other day. And it's a common theme. I mean, it goes back to LHRH days. But that is the challenge. It's not who has prostate cancer, who has significant prostate cancer that needs to be treated. We need to reduce unnecessary repeat biopsies, and we will discuss that. And we need to stratify low risk from high risk cancer. In other words, we are going to pick up low risk cancers. And the question is, does that, just because we pick it up on biopsy, does that accurately reflect the tumor biology of the patient's prostate? And so the real question is, will prostate cancer markers help us? So let's just start pretty basic. What is a prostate cancer marker? Well, a biomarker is a molecule that can be found in blood, tissue, or body fluids that is a sign of normal or an abnormal prostate. And if you think about it, it can come from multiple places. It can come from tissue, it can come from blood, and it can come from urine, what we call these liquid markers. So that's what we think of as a prostate biomarker, is something that comes from tissue or liquid, urine and blood. Okay? Well, I will also challenge you that there's a fourth biomarker, which could be radiography. It could be radiography. And so this concept of multiparametric MRI and the use of fusion biopsy, where all of a sudden now the newer sequencings that are employed with the MRI system, it really, the role of MRI now is that with these new sequences, it becomes potentially a more physiologic test. Now, so the question is going to be, is this another form of a biomarker? Well, the reality it just happens to be imaging based. And I will tell you, as Dr. Baza said, to me, I also delve into this realm of this post-macro world in which we're now living, with basically, as we move from volume to value-based medicine, is that I'm a big believer that, urologists, we need to maintain some element of not necessarily control, but management, and be very well versed, not only for who to biopsy, but appropriate management for localized therapy, as well as management for when these patients progress. And there will be patients that will progress into this advanced cancer and advanced prostate cancer world / CRPC. So again, you can have tissue-based, you can have liquid-based, urine and blood. But I will also tell you that I would consider imaging as potentially another role of a biomarker. And again, this will probably, as we move forward, be all complementary. So, as we look at the buckets of prostate cancer, so this is where we're going to start to get into the meat of this thing. So when we look at buckets of biomarkers, so I try to put these in 4 particular buckets. And again, all these tests that we're going to talk about, really, you have to understand what bucket in which they play. So the first bucket is really who to biopsy. And again, there's a lot of tests out there. And when I put this slide together, sort of the big ones were PSA, obviously, Prostate Health Index, 4K, and Select MDX. Who to rebiopsy. So we all know that we do a lot of biopsies, and you have some negative biopsy. And the question really is, if you get a negative biopsy, does that truly mean they don't have prostate cancer? Or did you just miss it on your biopsy? So then you have a bucket of who to rebiopsy. So we're going to look at these together jointly, but again, you've got different testing in the who to rebiopsy. So you have confirmed DX, you have a test called PCA3, 4K may also help you there. Then you have a bucket of who to offer interventional therapy, active intervention as I call it, versus no therapy or active surveillance, what we used to call watchful waiting. And I'm glad we actually changed that terminology of watchful waiting, because I had patients say to me, okay, well, what are we waiting for me to die? No, so now we have what's called active surveillance, but the problem is there is no protocol that's standardized for active surveillance. What my brother does, what Dr. Abaza does, what I do, what an academic center will do, it's going to change. And right now, there is no standardization. So the question, there is a bucket here. There are some tests designed for who is a candidate for active intervention versus active surveillance. And so again, you have a series of tests here. And then the fourth is who to treat or not to treat post-prostatectomy. And again, what we know from a histopathology standpoint is that patients with higher grade prostate cancer, particularly if they have pathologic T3 or greater, the recommendation is those patients probably will do better with adjuvant radiotherapy to the pelvis. Now, as we all know, all T3s are not alike. All Gleason 3+3s are not alike. So again, there is some testing available from a biomolecular standpoint of who may be the appropriate candidate for adjuvant radiotherapy post-radical prostatectomy. So that's how I want you to really think of these buckets. Who to biopsy, who to rebiopsy, who needs active intervention versus active surveillance, and who to treat or not to treat. And there's probably another bucket out there which will actually get addressed towards the end. So, this is a slide, and it's far from being complete, of the number of prostate cancer markers available. I stole this from my friend David Crawford at the University of Colorado. So again, when you look at who to biopsy, you've got Prostate Health Index, which is from Beckman Coulter. You've got 4K from OPCO. Then who to rebiopsy, who to treat post-surgery. So we're going to kind of go through all this, and I'm going to try to leave enough time for if anybody has questions. But again, that's how you sort of need to be thinking about prostate biomarkers. So, who to biopsy or who to rebiopsy. So we know the standard, I don't think anybody would disagree with this. The standard for diagnosis of prostate cancer is your typical ultrasound-guided 12-core truss biopsy. So we know that 25% will receive a false negative result, 15% will suffer complications, and about 3%, because of the biopsy, will actually get hospitalized due to bleeding and sepsis. So prostate biopsies, even though historically speaking, 1 million are done every year, carries with it some element of complications. So these are, we think of it for the most part, we think of this as somewhat benign. We do it all the time. But when you look at large series, that it is associated with some complications and some risks. And again, it seems to me that whoever gets these complications, it always seems to be an attorney or a friend of one of your buddies. That always seems. But I think these are these real numbers? I think some of this may be inflated, but again, it is an issue. So again, associated complications with biopsy, you get bleeding because of hemorrhoidal vessels. You do get infection. Remember, we're still for the most part transrectal. You've got some sepsis or bacteremia. This is markedly different. Probably, let's see, Bob and I guess we were the only ones that trained during the 80s, but basically, before we had transrectal ultrasound, these biopsies were much, much more difficult. I mean, they were transperineal. We had an 18-gauge true-cut biopsy needle, and if you went transrectal on those guys, the incidence of bacteremia was close to 80%. So transrectal ultrasound and 12-core biopsy did represent a real progression. But again, still, even with that technique, it does have some complications. Now, there seems to be some more data, especially if you're going to do templated biopsies or systematic, basically saturation biopsies. There's some data coming out now that it worsens with sexual dysfunction. But the real problem, I believe, listen, this is 12-core biopsies are much better than where we were in the 80s. Much better. Can we do better? Absolutely, yes. But the real problem with traditional 12-core ultrasounded biopsies is that we have significant undersampling and we have significant understaging. So just because you pick up a Gleason 3+3, does that really mean they're 3+3s? Again, this addresses the whole heterogeneity of prostate cancer which exists. So this was sort of this landmark article that was published by the Hopkins people. So basically this article, which was published in, I think, 2013, 2014. So what they did is that they went and looked at the Hopkins database, and they found over 7,100 patients who by definition,